Today, I'm doing the first ever second interview for the podcast, and that's because the first interview with Dr. Donny was so successful. We thought we would follow it up with some new questions, and particularly as Donny has successfully launched his new book, which is called Behind the Smile. And I think for those of you who are lucky enough to read this book, as I have been, it follows the journey of a young lad who really was put in the too hard basket. But Donny, by going through a syntax of care, which we're going to talk about in this podcast, was able really to help him with his spectrum disorder. And I think as a bonus, gave him amazing looking teeth. But that's why I love the title, Donny, Behind the Smile, because, if you just look at his teeth, like most orthodontists, you don't really get the bigger picture about his behavior and his breathing and his quality of sleep, et cetera, et cetera. So let me introduce Dr. Donny. Donny's a myofunctional dentist who's dedicated to uncovering the hidden reasons behind children's health and developmental challenges, which is why this book is so good. And what began as a curiosity about why some children struggle to eat, sleep, breathe, or grow like their peers became Donny's lifelong mission to help families to find answers. So through his compassionate whole child approach and collaboration with many other healthcare practitioners, including body workers, physios, chiros, lactation consultants, etc., Donny supports natural growth and function, giving every child the best chance to thrive. Now, I've actually read that little review from the back of your book, Donny. So if we can start by number one, welcome you and congratulate you on the book. Can you tell me what was your motivation in writing this book?
Thank you very much, Derek. Thank you for having me back on your podcast, Ask the Orthodontist. My motivation was that I've been seeing too many families going through a very, very long journeys trying to find answers and trying to find solutions or even hope, just a little bit of hope in terms of their children's functional health. And at my practices in Melbourne here, like all the dentists that are practicing at the practice actually see this on a daily basis where families come having seen quite a number of practitioners and they've all been told there's nothing else that they could do. They will grow out of it or just wait and see. But, what we see is not just about the child struggling in terms of, their health and through their functional symptoms and so on, but also the parents are struggling to be able to manage and cope in terms of how to raise that child. So it's not just affecting the child, but affecting the whole family as a system. So, there are so many parents that are looking for answers and not wanting to understand, I suppose, what should they be looking for and whether there are any options, whether there are any opportunities that they can look for, they can go down the path of instead of just waiting to see and then to see whether they'll grow out of it, right? So that was the motivation of the book. And so I'm hoping that it will reach as many parents as possible. I didn't write the book actually for practitioners. I wrote it for parents. And that's why it's following a story of one of my patients. It's actually based on a true story. And so I wrote it in a way that is fiction, even though it's a non-fiction book. And that's my intention.
Great. Now, I would say if you were to rename, Behind the Smile, which now that I've read the book, I understand it's the story of Ethan. But I would almost rename it, uncovering the hidden causes of your child's everyday struggles, right?
Yes,
That's
true.
Ethan's story, right?
Yeah.
So there's a couple of paragraphs that I've pulled out of the book that I think parents would love, and maybe we can start by answering some of those. One of the questions you posed in the book, why does your child snore, grind their teeth, or wake up tired every morning? Because I think we all have patients who have these problems, and parents, of course, either think it's normal or have been told they'll grow out of it. Can we start with that question? What do you think one of the common causes of snoring, grinding the teeth, and poor sleep are in children?
Well, I see pretty much a lot of these symptoms on a lot of, maybe more than 90% of my patients, and they have seen, like ear, nose, and throat specialists, medical GPs, and a lot of them just telling them, oh, snoring is normal in children, right? And snoring is actually never normal in any age group, in my opinion. And yes, often it's very difficult to find the root cause of what is going on because it could come from a number of different factors. But one of the most common ones that I see is actually more of an airway issue, where there's some kind of a narrowing of the airway or obstruction of the airway, which could be coming from the level of the nasal cavities or behind the nose, the pharynx, and even from the mouth, where the tongue is probably collapsing backwards and narrow the airway, especially when they're asleep. So, snoring is a sign that there is some kind of a narrowing of the airway, because the air that's going in and out through the airway is hitting turbulence, and turbulence, the noise of turbulence is actually snoring. And if that child is having a narrowed airway and they are sleeping, say, in a horizontal position, and the airway is so narrow or even obstructed, the body's response is to actually to try to find more oxygen, in a way, to be able to breathe again. And if their mouth is closed, they tend to actually start to grind their teeth, because their lower jaw will need to move to be able to open the mouth and try to get more air through their body, because the body's way of working, of functioning, is always in that survival mode, right? So the snoring, the teeth grinding, means that the patient's sleep quality is not great, because that airway is compromised, and they're not going to undergo through the entire sleep cycle that they're supposed to go through. And often what happens is the snoring and the teeth grinding happens in the second or third stage of sleep, where they haven't gone into the recovery stage, or into the growth stage, and they get woken up, and then they would go back to stage one again, which means that they get tired in the morning when they wake up, even though they've slept like 10, 12 hours that night, but their quality is not great, they would still wake up tired. So it's not about the quantity of the sleep, it's about the quality of the sleep. And you've got to look at the airway, what's going on with the patency of that airway, what's going on with the, with the snoring, the teeth grinding, and how that's all going to affect the quality of sleep.
Look, I think we've had this discussion before, but many medical practitioners just purely will say, look, I don't know, send the kid for a sleep study. And as we know, there's no real scientific data to support children's sleep study and AHI figures. There's good research on adults, but I find children, because they're quite active, they don't really collapse for long enough to really recognize an apneic event. So when kids come back, it's almost like, the parent says, well, I've done the sleep study and my physician says there's nothing wrong with my child. He doesn't have sleep apnea, but you and I know he has a hell of a lot else going on. So I'm not a big fan of pediatric sleep studies. I think we treat to the symptoms, which is why you continued in Ethan's journey to look beyond that. A great point on bruxism. I think every dentist needs to learn this point, even though this podcast is for parents, and that is, grinding of teeth we view as a bad thing because it's damaging what we look after. But really, the body uses as a protective mechanism. That overactivity stimulation of the jaw muscles is actually opening up the airway, and using that link to the junior glosses to get the tongue out of the way. So I think you shouldn't ignore the snore for a child, number one, and definitely you shouldn't ignore the fact that they're grinding their teeth. And if someone suggests, I'll just give them something to protect their teeth, that may not necessarily be treating the cause of the problem rather than just a symptom. Donny, a second sort of question, and again, it's one of the questions you pose in your book. Why do children have trouble focusing at school, struggle to feed and eat, speak clearly, or breathe through their nose? Can you give some insights into that? Because that, again, I'd imagine would be 90% of your patients.
Yes, absolutely. I think one is going back to that sleep quality, because if someone is overtired and they wouldn't be able to focus and concentrate at school. And I see so many of the children having that problems going through school where, nowadays in my initial consultation, I even asked the parents, has there been any mention of this kid's focus or concentration from their teachers, because the parents may not realize what's going on during the school days, and the kid would come home and feeling tired, and the parents would think that, oh, he's tired because he's gone to school, right?
Yeah. Yeah.
But there's actually been focus and concentration issue throughout the day at school during class and so on. And that's probably because of a lack of sleep. And going back to that airway narrowing and so on, when the kid is struggling to breathe and not having that good quality sleep, they are more in that sympathetic overdrive, which means that they're in that fight or flight mode all night
Yeah.
long instead of having rest or digest. So they're not recovering, their brain's not actually healing and not getting rid of the waste products that's supposed to happen during sleep, because they're not undergoing through all those stages of sleep. And so obviously when they wake up, they are super tired. They could present themselves as being hyperactive even,
Yeah.
because they are so exhausted, right?
Yeah.
Imagine if you and I, yourself, if you don't have a good sleep, say the night before, in the morning, you would be pretty tired, you would be pretty grumpy. And, because your body hasn't recovered and hasn't healed from what's supposed to happen during sleep. And that can really affect the focus and the concentration. So I feel that, a lot of these behavioral issues that we see in children could actually come down to the child not having enough sleep and not having enough, good airway where they can actually do functional, healthy breathing, not only when they're awake, but during sleep as well. So, I think it's very, very important that for whoever practitioner that you're going to choose to have a look at your child, that they are going to have a look at that child and assess the child from a functional point of view, not just from a
Yeah.
structural point of view, simply because of all these domino effect that could happen when the functions compromise in that child. Yeah. Mm.
Fantastic. And I think parents should also be aware that the proper diagnosis of ADHD is not just a 1 minute consultation to say, oh, yeah, my child's not doing well at school. He's a disruptive kid. We need to medicate him, because I think Australia is probably most guilty of oversubscription or overuse of meds for ADHD. Recent studies, as you know, can show that 50% of kids who are diagnosed with ADHD actually don't have genuine ADHD. They just have sleep disordered breathing. So I think, rather than just go down that pathway, maybe get a second opinion. And I think what you just said hits that nail on the head. Donny, there was a very good chapter in the book. In fact, all the chapters were great. And I think I did the lazy thing, I must admit, when I first got the book. I read your summaries, and they were really good. And then I had time, literally, because we went on leave a few days ago. I read the book cover to cover. It was really good. And I felt that I felt like I knew Ethan. Now, as an orthodontist, I was super impressed with the end result you had with his teeth. But that's my orthodontic training, right? And to be able to achieve that with a method that's still probably not mainstream, I thought was fantastic. But one of the things I always get asked as a specialist orthodontist is, look, why do we need records? And my dentist already took records, and then my staff spend 2 hours chasing these records to find their bite wings of the teeth. That was what the parents thought we needed. So chapter 5 was really good in talking about the importance of records. For the benefit of parents, can you run through, I know you met Ethan. I know you did a very good medical history. You chatted to the mum and got her input on what was going on. But then before you launched in and started any treatment, you took records for a correct diagnosis. Could you just maybe talk briefly to parents on what are records and why we need them, what we use them for?
Sure. Records in my clinic means that we take quite a number of photos of the patients, not just the teeth, the jaws, but the tongue attachment, even the pharynx, so behind the mouth itself. We try to take photos of that and see what's going on with like the size of the tonsils, for example. We take photos of their smile, their face from different angles. We also take photos of their posture, even from the back, because we would like to see if there's any asymmetry or, any postural compensations when they stand. So it's not just photos of teeth and smile only, it's photos of the whole patient. And we also take videos on how the patient speaks, chews, swallow, move their tongue around, move their lips, because we would like to see how the muscles of the mouth and face are functioning and posturing. We also take 3D study models. These days they are digital, so we have a digital scanner that takes quick photos of the teeth and the gums and immediately reproduce them as an animation on like a giant iPad. And kids usually love it because they can see their teeth appearing on the iPad. And also we take X-rays nowadays. We take at least 3 different X-rays from 3 different angles of the head. So from the side, from the front, and also for what's called a panoramic X-ray of the jaws. But if the patient has more of a compromised airway, often we also need to take cone beam CT scans, which actually are 3D representations of their heads, which allow us to also be able to measure their upper airway volume and so on. And by having these records, then each of the dentists is able to analyze and measure not only just the size and the shape of the jaws, but also the positions of the jaws, where they're supposed to be in regards to the whole head, in regards to the whole skull. We're also able to, I suppose, quickly evaluate the posture in terms of how the patient is standing and what their neck posture is like, because all these things can be related to an airway issue. If someone is struggling to breathe and having narrow airway, they would tend to posture their head and neck forward more to open up their airway. And all these records can also show us if there's any restrictions in the muscles of their mouth. For example, if someone has a tongue tie or a lip tie or cheek ties, that could be affecting the posture and the function of the muscles of these mouth as well. So with these X-rays and photos and videos and 3D study models, we are able to understand the patient completely, not just from the functional point of view, but also from the structural, because they go hand in hand. But also, all these records may uncover hidden things that we cannot see. As you know, I have sometimes referred patients to you with like an impacted tooth, for example, that that we need the help of someone like us, like you, like a specialist orthodontist, to be able to put that tooth in position, right? Because these are complications that often we cannot see just by looking in the mouth without records.
Yep.
So it's very, very important to gather these records to be able to give us the big picture and actually formulate a treatment plan that is suitable for the patient, or even to give us, the myofunctional dentist, to say that, look, the type of problems that you have is quite complicated, and there's unexpected things that is showing up here, and we are not the right people to help you. In fact, we need to refer you to the specialist orthodontist or to someone else, you see? Yeah.
And looking at the records you took for Ethan, parents can easily see page 42, the narrow palate, and the fact that lower jaw is trapped by that upper jaw being narrow, and exactly that forward head posture of Ethan. So it'd be good for parents to kind of look at their own kids in that regard. As you know, I recently completed my PhD after 15 years of research. And one thing that we concluded is that from looking at records, particularly the position of the jaws, we can also predict now who has sleep disordered breathing. And I think that's an important thing for parents. They might come in wanting their kids' teeth straight, but really by taking full records, we can talk more about the airway. And I'm glad you're a big advocate of CBCT, as am I. It's a very low radiation X-ray, but it really allows us to map out some of the problems associated with their breathing. So, Donny, I'll lead you to another page that I thought was fantastic. Page 15 of your book, you mention comfort sucking and mouth development. And many parents, to this day, still let their kid have a pacifier, still let them suck on a blanket. And they know it's wrong, but maybe they don't realize how bad it really is. For parents, can you link, what this comfort sucking may be caused by, some ways of eliminating, and if they don't eliminate, what are the consequences?
Well, this comfort sucking, we're talking about children who are sucking on pacifiers or thumb sucking or digit sucking and so on, or sucking on like objects like a bunny doll ear or things like that. And it's their way of soothing themselves, of trying to find, I suppose, a state of comfort, right? The problem with these comfort sucking is because they are non-nutritive sucking habits. They can cause quite a number of issues. First of all, the jaw development can get affected because when you are comfort sucking, imagine if you're sucking on a thumb, and what happens is it actually pushes the upper jaw forward, and it becomes more triangular and pointy. But also the mechanics of the suction itself actually activates your cheek muscles quite a lot. So it overactivates your cheek muscles. And if you think about it, if your cheek muscles are overactivated, they're going to be pushing forces inward. And underneath the cheeks are going to be your upper jaw. So say you are sucking on the thumb is actually pushing up against the roof of the mouth, pushing the upper jaw forward. And then the cheeks are pushing the upper jaw from the sides inward, which means that the upper jaw is going to become narrow, and that thumb is also going to hold the lower jaw back instead, and hold the tongue down as well, which means that it can also cause more of the low tongue posture and that receded lower jaw, so with the retruded chin and so on. And when they have the teeth come into play, that means they're going to have a gap between the upper and lower front teeth, a horizontal gap, which in the dental terms we call it overjet. But it also means that the top and bottom front teeth cannot meet together to function, and so it can result in what's called an open bite, where where the front teeth are unable to meet together. I think a lot of the times with comfort sucking, yes, there has been some babies that I feel that probably do need a little bit of comfort sucking to be able to soothe themselves, but a lot of the times it's maybe an easy way out that that parents have been told to just give the baby a pacifier, so that it suits them. But you got to sometimes try to look deeper in terms of why the baby needs a pacifier or thumb sucking or finger sucking. And often in my patients, they may actually have low tongue posture or even a tongue tie in which the tongue is unable to rest and stimulate the palate. And on the palate is part of the jaws of part of the upper jaw, and this upper jaw is connected to the cranial system, right, to the bones of the skull. And so when the tongue is resting and posturing and functioning against the roof of the mouth, that palate, that roof of the mouth, actually has some mobility, have some movement, and the pressure from the tongue actually gets transferred to the palate and gets transferred through the nasal and the pharyngeal cavity, and it actually gets transferred to the base of the cranium where the brain rests on. And all these movements and posturing of the tongue creates that mobility of the cranial system, which actually activates the nervous system and activates the fluidity of the whole cranial system. Like in the brain, for example, is covered by what we know as the cerebrospinal fluid that needs to flow. And if the tongue is doing this pumping, in a way, pumping mechanism of that cranial system, the fluid starts to flow and lubricate the brain and able to get rid of all the waste product during sleep and so on. But if the tongue is not resting against the palate and not actually activating that cranial system, that's when the child needs to try to replace it with something else, right? And that could be a pacifier, could be the thumb, could be the finger, could be the bunny ear. So, so have a look deeper, I suppose, when we're looking at kids who can't get rid of their dummies or their thumb sucking habits or finger sucking habit, look deeper in terms of what is causing that. Sometimes I do work a lot with cranial osteopaths or cranial chiropractors, where they're going to have look at that child's cranial system and see if there's any cranial strains that could be related to the child needing to, to comfort stuff all the time. And it's very, very difficult to eliminate that habit. So sometimes we have to go from that cranial approach and then see what is going on, and that could be the cause of that damaging habit that could damage the jaws and so on. And if the parents don't stop these habits quickly enough, the jaws grow like I think the statistic says about 50% of the jaws already completed growing by about 4 years old and 80% by 6 years old, So you can imagine if the damages to the jaws from these comfort sucking have already occurred in the first 2, 3, 4 years of life, it's going to be more challenging to undo it and to correct the jaw development later on. Yeah.
And both you and I have taken Bob Walker's courses many
Yeah.
times, and when he talks about the sphenobasal pump
Yeah.
and the whole stimulation, I think that's something dentists should maybe pay a little bit more attention on, because it's going to throw the whole body out. And I know you're very big on showing parents how to do a suction hole so they can see if their kid's tongue sits within all their upper teeth or sits on top of the teeth. Because if it sits on top of the teeth, that's a high sign that it's not doing its job. And maybe that could be the way of changing that habit. So very, very interesting stuff. And that leads me on to my next point. And this is again following Ethan's story. In page 34 of your book, you talk about the bedwetting, which obviously Ethan had a concern with, which improved after the work you did. Could you just lead parents through the link between high palates, narrow jaw, poor tongue posture, and potential nocturnal enuresis?
Sure. Well, a lot of my patients that have, high palate, narrow jaw, low tongue posture, they are more likely to have dysfunctional breathing, which means that they're not going to have the correct balance of oxygen, carbon dioxide, and nitric oxide going in and out through their whole system, which means that their body organs are not getting the proper oxygenation. And what happens if that occurs is the body becomes in the state of hypoxia, which means that they're lacking oxygen. And when there's a lack of oxygen, the body becomes in a more acidic state, which means that the body needs to maintain a balanced pH. And by doing so, needing to maintain that balanced pH, they tend to expel urine, because when you are in an acidic state, the first thing that would go into spasm are your smooth muscles, and the bladder is basically covered in smooth muscles. So the bladder would become activated to actually expel some urine, expel some hydrogen ions to actually maintain a balanced pH. So, a lot of the times when I see a kid bedwetting, I usually would see them having a dysfunctional breathing, they could be
Right.
mouth breathing, they could be chest breathing, and so they're not getting the proper balance of the gases to actually oxygenate their organs.
Perfect, perfect. And I know, in my limited research, when we looked at kids that we did expansion versus the control,
Yeah.
we found that 8 out of 10 kids were dry almost instantaneously. So there's a lot to be said about the width of the palate.
Yeah.
But definitely, I think modern medicine really puts these kids in the bedwetting alarm and they'll grow out of it scenario, where it's frustrating for parents when you've got a kid who's nearly ready for high school, who can't do a sleepover, and mum's working full time and having to wash bed sheets every day. So I think it's really interesting that, and maybe more research should be done in this field. I know Donald Timms was one of the first guys to talk about this, but if you are a parent listening to this and you have a kid who's still bedwetting, past the normal age, then maybe it should be a case of reading Donny's book and having a look at some of the symptoms associated with the tongue posture, the breathing, the width of the palate, et cetera, et cetera. Now, Donny, your favorite topic, which I would say is also very well written in chapter 6, is, and I love the title, Tied in Silence. That's fantastic, right? So can you just briefly explain to parents, how could they possibly tell their kid is tongue-tied? I know I give parents the little Myomate ruler, and I get them to do the measurement at home just as a guide. And it's amazing. It's probably not good for cross infection, but they actually lend that ruler to all their relatives who also use it. uh, but I really liked your page 57, deep frontal line of fascia, and you're the one who actually taught me about how linked a tongue tie is almost down to your toe. Because there can two topics here. Can you chat about how a parent can maybe look at an anterior posterior tongue tie, and secondly, what are the problems for the whole body associated with a tie?
Sure. So, well, every tongue has an attachment, like there is a string under the attachment, and about 1 in 10 tongues, the attachments are too tight or too short that it affects the posture and the function of the tongue. But it also doesn't just affect the tongue itself, because this string or this attachment under the tongue is like your inner skin. Your inner skin is called the fascia, and fascia is actually like a connective tissue layer that covers pretty much every organ and every muscle inside your body. So fascia has different lines in the body, and the one that is related to the tongue is called the deep frontal line, which connects the tongue all the way down to your toes. So it travels down on the inside of the front of your body. It covers your diaphragm. It goes down your thighs. Then it twists itself behind the knees to your calves, and then go to your heels, and then underneath your sole, and then to your toes. So, so when there is a tongue attachment that is restrictive in terms of function and posture, that means that it's not just only the tongue that could be affected, but it's also the effect could be downstream, right down to the very bottom of your feet, right? That affects your posture and your breathing and so on. I've had, actually, there's been about 3 adult patients in the past month or so where we would be doing a functional release of a tongue tie, and then immediately after they said, "Oh my goodness, how come I can suddenly breathe better? It's like my whole diaphragm just opened up." And they didn't know any different before that, because whatever they were doing before was normal to them. But suddenly, when things are open up and they could feel the difference, they could feel the improvements, they're going, "Wow, I never realized that I wasn't actually able to breathe properly beforehand." And it could be because of these fascial restrictions, right? So
Yeah.
a lot of the symptoms and signs that parents should look out for is, first of all, it could affect anyone in any age group, really, because tongue ties form before birth. So when you have a baby, have a look at whether they are able to breastfeed, for one, whether they are able to bottle feed, even if you're not breastfeeding. What are they doing in terms of chewing and swallowing their foods? Are they able to move the food around in their mouth, or are they like gagging or choking and not wanting to swallow foods that are more tender and more chewy? Are they mouth breathing, and are they snoring during sleep? Are their teeth grinding during sleep? Are they waking up in the middle of the night? Do they have good quality sleep? Are their jaws narrow? Are when they haven't got their adult teeth yet, are the baby teeth actually spaced out evenly? Are there gaps in between the teeth that shows that the jaws are actually widening and developing well? Because if the baby teeth are very, very tight and they don't have any gaps, and they may even be crowded already, the adult ones have no chance, pretty much, because the adult teeth will be a lot bigger in size compared to the baby teeth. Have a look at their posture as well, whether they have that forward neck, forward head posture, whether their shoulders are rolling forward, whether their hips are actually posturing forward as well, and have a look at their speech. Their speech could get affected. The speech development could be a bit slower. There could be certain sounds that can get affected in terms of their pronunciation. So all these things are actually going to give you an indication whether there is something going on. And look, these signs, they may not be because of a tongue tie, but they could be related to a tongue tie. Having a tongue tie doesn't mean that it is the root cause of everything either, but it could be just one of the causes that you may need to have it assessed and have it managed so that you can actually tick one of those boxes. Yeah.
I know when I firmly, well, because in orthodontic school, we never taught about tongue or lip ties, but
Mm.
after I'd realized, what damage can cause, I was probably referring to the wrong person. I was referring to an oral surgeon who was using those diode lasers. So basically, he was scarring the tissue. And then what I realized is that some of that scar tissue then prevents the normal function anyway. So I noticed now that I send my cases to you, you work with exercises before, during the release, and after. So maybe if we could go to chapter 9, where you talk
Mhm.
about the myofunctional exercises. Now, I love your analogy, and I remember when I very first came to your practice in North Melbourne, I
Mhm.
liked the waiting room, which was like the onboarding for the plane, and then boarding the plane, and then the takeoff, right? So I think chapter 9 you call lift off, which is talks a little bit about the exercises that the kids need to do, and also the body work. So can you just lead us through, maybe, in Ethan's case, you diagnosed the tie, you've done it functionally. I saw the diagrams, they're beautiful, no scar tissue like what I used to see.
Mm.
Could you just lead the parents through then what the kid needs to do, which obviously Ethan did extremely well, which gave him the results. So what are some of the tongue exercises you do post frenectomy?
So with Ethan's case, he was 10 years old when I first met him, and tongue ties are formed at about 12 weeks in the womb. So he had the tongue tie for, 10 and a half years already. And so his body was actually, and especially the muscle of his mouth and face, were already used to functioning and posturing with the tongue tie there. And so if you talk to me probably about 15 years ago, Derek, when I saw a tongue tie, I used to just release the tongue tie and expect everything to just heal really well. And I would say, in my experience, about 90% of the tongue ties I did back then actually grew back, right? And that's
Right.
because it's like skin tissue. It's like your inner skin. If you get a scratch on your hand, and that scratch would want to heal back because the skin's covering all the organs and the muscles underneath it. And if that skin doesn't heal uh, back to the original, and it's got scarring and it's got that restrictions, it would restrict the actual movement of the muscles. So what happens with the tongue tie is, if we just release the tongue tie without any exercises, especially if the tongue tie's been there longer, there is more likelihood, in my opinion, that the tongue tie can attach back, because the muscles are so used to having the tongue tie there to be able to function and posture. So that's why nowadays, probably in the past 10 years or so, we would actually implement exercises for the muscles of the mouth and face and around the neck as well. All these muscles that's got to do directly with the tongue, to be able to prepare these muscles to start to think differently, right? And say the tongue has a tongue tie, but it's unable to elevate towards the roof of the mouth. And so it's been thinking that, okay, I can't actually elevate towards the palate, so why even try? So these exercises before the actual tongue tie release itself is to actually recreate the neural pathway from the brain to the tongue, to say to the tongue, hey, tongue, I want you to try to elevate towards the roof of the mouth. Yes, you physically cannot do it right now because you still have a tongue tie, but you need to be ready for the change in function and posture once the tongue tie is released. So I usually would implement about 4 weeks of exercises before the tongue tie release, do the tongue tie release, and then after that, actually implement at least another 4 weeks of exercises to teach the tongue and the muscles of the mouth what to do. And so when these muscles have been prepared, or we call it prehabilitated, and then we do the release, and then we rehabilitate the tongue and the muscles of the mouth and face. In my experience now, the rate of the tongue tie growing back has been under 1%. And I think that's why that having that functional approach of a tongue tie release is very, very important, because that I'm seeing the difference myself in my own career, and how I'm doing the program differently now, and so it's been a lot more success and a lot more helpful for the patients. You see, so yeah.
Right. Perfect, perfect. Um, Now, there was a interesting paragraph, page 107 of your book now, and I'm mentioning these pages because when people listen to the podcast and have the book, they can actually refer back to it. But you talk about the work of now. I hope I'm pronouncing it correct, Dr. Stephen Porges,
Yep.
neuroscientist and psychologist. And he has this theory, the polyvagal theory, which I found very interesting and links to a lot of the stuff that you do. Could you please explain to parents about that theory and how the balance in the body of the oxygen, CO2, nitric oxide?
So the polyvagal theory, yes, that was discovered by Dr. Stephen Porges, who is an American psychologist and neuroscientist. And so he's talking actually about the vagus nerve, which is the cranial nerve 10. Now, the vagus nerve is the longest nerve in our body. It comes from a Spanish or Latin word, I think, that means the wanderer. So it's the one that travels the most, and it travels all the way from your gut to your brain, basically. So this vagus nerve, it controls like a lot of your emotions, behavior, and physical health as well, because not only that it supplies actually 75% of the parasympathetic nervous system, but it also has like a sensory motor and also a social aspect of it. Now, this vagus nerve is important, as I said, 75% of the parasympathetic nervous system, which means that it needs to be activated well, and it needs to have a high vagal tone, which means that the parasympathetic nervous system is working well to be able to switch between sympathetic and parasympathetic. So parasympathetic means it's your rest and digest, right? And the vagus nerve needs to be able to control that parasympathetic nervous system when you need to rest and digest. But if you have low vagal tone, if your vagus nerve is not activated properly, you're more likely to be in the sympathetic state, which means that you're in the fight or flight. And not only this affects the nervous system itself, but it affects your behavior. So there are people who are under a lot of stress or trauma, and subconsciously they are actually more in that sympathetic state, and they may just shut down, right? They may hide themselves and don't want to interact with other people. It's because they're actually in a traumatic state. They're actually under a lot of stress. So when I work with a lot of my patients, for example, with Ethan, he's more of that low functioning in the spectrum. So so he used to not be able to look at me in the eye, looking around the corners of the room, wouldn't answer my questions, very shy, and so on. And he was probably in that actually sympathetic overdrive, but he's not the type of sympathetic overdrive where he was actually hyperactive and bouncing off the walls. It was low functioning, and
Yeah.
and he was hiding, behind his own body, like he's trying to hide and he's trying to protect himself in a way. And so with all these patients, I need to make sure that I understand what's going on in terms of why their behavior are like that, because it's not, like kids can be bouncing off the walls, but they can also be very shy and very introverted in a way, not saying a word, and just trying to hide behind this invisible wall, invisible screen, right? So the polyvagal theory has given me a lot of clarity in terms of how we can manage the different types of patients that go through the practice. Because when we prescribe exercises and so on, we've got to make sure that that patient is going to want to do the exercises and understand and actually do them, as we instruct them. And in Ethan's case, because of his condition and being, I suppose, unable to make himself comfortable in a social setting, we actually work very heavily with his mother, right? His mother was actually the one that instigated everything and knew how to deal with him properly. And at the end of the day, he was so compliant because his mother actually did a lot of the work for him and knew how to get to him, how to get him to understand the exercises and actually do them. So this vagus nerve is one that we look at a lot, subconsciously. We don't tell the patients that, I'm going to check your vagus nerve or anything like that.
Yeah.
But
Yeah.
but it is a very, very important nerve that can really affect the way each patient's behaving and how they're going to progress through treatment, right? And yeah, so if the patient is having dysfunctional breathing, more likely that they have low vagal tone, which means that they're more in that sympathetic overdrive. So we do have some exercises as well that can actually increase the vagal tone, like humming or gargling. And what's even better is gargling with your head looking up, your mouth open, and your tongue sticking out. That would really activate the vagus nerve that's at the back wall of your throat. So, so polyvagal theory has given me a lot more clarity in terms of how we can manage these patients, because they're all different. Yeah.
Perfect. Perfect. We move on to chapter 16 now. And, this
Mhm.
is really, if people ask me, 40 years into the field, what's the cause of malocclusion? I was taught, and probably you were the same, that it was all genetic, right?
Yeah.
And, mum had big teeth, dad had a small jaw, and the kid, had no hope in hell. I think we now realize that most of these malocclusions are epigenetic, environmental. We've talked about the breathing, we've talked about the tongue posture. I think diet and also the way you chew your food is really important. And I think when we look at our primitive ancestors who were hunter-gatherers, they didn't actually have malocclusions. So I like your chapter 16 in particular, and you call it the soft food problem, right? Could you maybe expound a little bit more for parents on ancestral diet and how, the way your kid chews and what they eat, and particularly at what stage to introduce these solids can affect the growth of the jaw?
Absolutely correct in terms of the primitive diet. We did not see a lot of malocclusion at all in the primitive society. Uh, in the 1930s, there was a Canadian dentist called Dr. Weston Price who actually traveled around the world and took photos of the modern society, people in the modern society, and also those people living in isolated communities who still had the primitive diet. And what he found was a lot of people who were relying on the modern diet, where the food's more soft and so on, they had a higher incidence of malocclusion because their jaws are narrow. Whereas those people who are living in these isolated communities, no access to any, modern facilities and surfaces and so on, they had actually really wide jaws with no malocclusion, and all 32 of their teeth, including their wisdom teeth, actually fitting in the mouth, right? And what he found was that the type of food that we consume can really make effect in terms of how the jaws are developing. So chewing actually stimulates jaw growth. And sometimes I see patients where they're only chewing on one side. That side that they're chewing on is going to develop that jaw wider because it's going to thicken the bone. But also the side that they're not chewing on, the jaw bones tend to grow longer and more vertical. So you can tell sometimes when you look at an upper jaw and it's not even, it's not symmetrical. If you take a midline of the palate, say on the left is much more narrow, on the right is much more wider, that kid is probably chewing more on the right hand side, right? So chewing actually stimulates jaw growth, and that's why whatever we eat, we need to make sure that we actually first of all chew on both sides. But also the type of foods that we eat, it needs to be more hard and chewy foods that can stimulate jaw growth. So ancestral diet is something that I usually promote, and I work with nutritionists that actually promote ancestral diet as well. And fundamentally, it's trying to eat foods that our ancestors used to consume for thousands of years, right? Because it's not actually a specific diet. It's not saying something like, you need to eat specifically this or that, but choose the foods carefully that is going to stimulate the jaw growth. Because if the jaws are growing, that means you're opening up your airway. That means you're going to have better airway health as well. So ancestral diet, things like, whole unprocessed foods, like, those without refined sugars or flours or seed oils or synthetic additives, foods that are eaten to their natural state as possible. Animal-based nutrition like organic meats and fatty cuts, bone broth, pastured eggs and seafood animal fats like tallow, lard, or butter. Nutrient density type of foods, like dense in nutrients, food that are rich in fat soluble vitamins like vitamin A, D, K2, minerals, and fatty acid. Fermented and cultured foods like sauerkraut, kefir, yogurt, fermented fish, miso, and also eat seasonal, right? Eat whatever the season is giving you, and wherever you are locally, right? It To me, it doesn't mean that, we hear all these blue zones around the world, like people are having the Okinawan diet or things like that. But if you look at the Okinawa diet, if you're eating so much of these rice and starch and so on, in Okinawa, it's probably really good because that's what's available there locally and seasonally. But if you try to implement that in Australia, where the climate's different, the geographically it's different, it may not be suitable for you. So it doesn't mean that a certain diet is going to work everywhere in the world. Yeah. Mm.
Yeah, perfect. Now we're getting towards the end of the book here, and as I said, we're just touching the surface on what I thought was very relevant for parents. But I think parents, particularly mums, and I think mums have I don't know, a sixth sense on what's best for their children, really. And I think Ethan's mum really deserves a medal for what she's done in this book. This book would be a great Mother's Day present too, I might add, Donny. Not that I want to take over your marketing, but I think this is good. You talk about ear, nose, and throat doctors, page 152, and we all know the importance of clearing the airway, and we both work with similar ear, nose, and throats down in Melbourne. Eric Levi's of the world, Perry Burston, Ryan DeFreitas, who are very dental focused. Maybe from a parent's point of view, could you explain why we need ear, nose, and throat doctors? And also, every second kid I know in Melbourne has an allergy. So, what are some modern methods parents can look at to rather than just give their kid Telfast every day? What are some ways we can control allergies which lead to mouth breathing? And what's the role of the ear, nose, and throat?
So in my practice, the ear, nose, and throat specialists play critical roles because they're the ones who are able to assess and address any airway issues. Because the airway issues could be within the nasal level or the pharyngeal level, and a lot of the ENT specialists that I actually work with, they do consider the myofunctional aspect of it and see what's going on there. It's not just a matter of just, removing enlarged tonsils and adenoids with every patient, right? And as you mentioned, in Melbourne, there is a lot of allergies, and I think that's the way it is geographically for us here in Melbourne because it's such a dry climate. I've had patients going on holidays to Queensland, and suddenly their breathing dysfunctions all gone, and they sleep much better, no snoring, and so on. And allergies play really a big part in this. Some of the tips that I would give the parents to look at the allergies is, first of all, find out what the allergies are. So we tend to send to an allergy doctor as well to quickly find out if they can pinpoint what are they allergic to. And there are some, I suppose, airway hygiene that we can do as well. So a lot of the kids, I ask them whether they're good at blowing their nose, for example, and some kids can't even blow their nose, right? So what we tend to get them to do is do some nasal rinsing, like non-medicated saline flushes through their nostrils every night, maybe to clear their nose. And a lot of my patients find it like they're surprised in terms of how much actually comes out from their mouth. And if they're able to clear that nose and clear that, that effect of the allergies that they've been exposed to all day long before they sleep, then they likely will have a better, sleep quality, but also making sure that their lips are closed, and sometimes training for that lip closure is going to make the sleep and the breathing even better as well. But also, having things like humidifier in the room, for example, I think from memory, the best percentage of humidity in the room is about 40%. And also some families actually live in areas where there's a lot of like dust and constructions going on, maybe even having an air filter that filters all these particles can actually help as well. And eating foods that are going to be more anti-inflammatory and not pro-inflammatory can really help as well. A lot of my patients are sensitive to like gluten, to sugar, to dairy, and so minimizing these and even trying to eliminate them from their everyday staples could actually also help. But the ENT specialists that we work with, of course, if there is physical obstructions in the airway, for example, adenoids or tonsils that are completely obstructing the airway, sometimes they do have to do some surgical intervention to be able to make the airway more patent. But working on that structure that the ENT can do, it doesn't mean that the breathing issue is going to get resolved straight away. They may get the immediate result or the immediate improvement. However, as I said before, if the body is so used to working a certain way and things change, it doesn't mean that they're going to change the way they work either, right? So if that patient has got a breathing dysfunction, mouth breathing, chest breathing, and so on, because there's upper airway obstruction, once the upper airway obstruction's been eliminated, it doesn't mean that they are going to straight away develop functional breathing. Sometimes they do need retraining. They do need the orofacial myofunctional therapy to get that tongue up, close the lips, and start breathing through their nose as well. Yeah.
And I think that's a valid point. Certainly the ear, nose, and throat doctors I work with, or in all my practices around Australia, that they always tell parents, we've cleared the obstruction, but now you've got to learn to teach your kid. Your kid's got to learn how to breathe. We teach our kids how to talk. We teach them how to walk. We've also got to learn to teach them how to breathe properly if they've been mouth breathers for so long. And I always say to parents, look, if we don't address the cause of the enlarged adenoids and tonsils and we just keep removing them at will, they're going to regrow. And I think they're also a symptom, but what is the cause? And I think mouth breathing is good. Allergies are good. The ear, nose, and throats I work with will do patch tests, skin prick tests, blood tests to identify those things. So that's a great point. Now, probably the most important diagram in the book for me, at least, Donny, page 163. You have your puzzle. I like the opening of that chapter where you say, look, you thought it was easy getting a puzzle that says 500 pieces, but when you open it up, it feels like it's 1,000,000 to put together. Yeah, that's a good analogy for when we're talking about multidisciplinary care for these kids. So could you just guide us through, Donny? You call it the puzzle on page 163, and it's really, I think you link in everything in the book and everything you talk about. Can you just guide through the layperson if they were to laminate that and stick it on their wall? How could you guide, habits, posture, timing? Is there a syntax of care?
Basically, I created that puzzle because I would like to make sure that everyone out there realize that, as a myofunctional dentist, we don't just look at teeth and jaws, we look at the whole person, right? And we're not just looking at the person that is in front of us right at that moment, but we got to have a look at their functional history as well. So this puzzle actually covers everything, even since before they were born. I've had a family just came in, like a few months ago, where they brought two kids. But the patient was actually only one of the kids, right? The second kid was not a patient. She just happened to tag along. And the main concern for this older kid was that he wasn't sleeping well, he was dysfunctionally breathing, and so on. But the second one had no issue at all of these concerns. So both grew up in the same family, same parents, same food that they eat. So I was like, what's the difference here? What is the difference? So I asked the mother, did anything happen during the pregnancy that was very different? And at first she said, no, everything was the same. And then it clicked on her that with the first one, she was actually undergoing a lot of stress at work to a point where she actually even fainted while she was pregnant with him, right? So because of all that stress, low vagal tone, again, the polyvagal theory, and so she was, in sympathetic overdrive. She was dysfunctionally breathing. She was hypoxic. She wasn't actually having enough oxygen for herself, let alone for that baby that was inside her. So he was already disadvantaged, this boy, before he was even born, right? So once we know that could be the difference in the pregnancy between the two kids, now we can pinpoint even better in terms of what's the root causes of why this kid is dysfunctionally breathing, not sleeping well, have narrow jaws, and so on, right? And sometimes it gives the family a clearer picture, because that's actually almost like a closure for them to find out that, oh, this could be actually the reason. It's not because I'm doing anything wrong, or because a lot of practitioners that these families tend to be very quick at putting blame on the parents, right?
Yeah.
But that may not be the case. Sometimes it's conditions or situations that the parents cannot control. So this puzzle gives a lot of people, I suppose, a really good overview in terms of what we look at. We look at the what the mother's health condition was like during pregnancy. Was she under stress, trauma, substance abuse, even marriage difficulties, or things like that. And then what happens when the mother was giving birth? Was the baby actually in breech or needing C-section or delivered naturally? Was there any instrumentation like forceps, vacuum, and so on that could distort the cranial system? What happens with their feeding? We look at the fascia, we look at their posture, we look at all those non-nutritive sucking habit, and so on. So it connects and connects and connects, and even look at the environment, how the epigenetics has really influenced the way that kid grows. So I think this puzzle, when I look at a patient, I'm going through the puzzle in my head, thinking that how far back do I have to take this puzzle, right?
Yeah.
And to find the root cause of what's going on. Once we know what is going on, and if we can really pinpoint that root cause, then we can actually direct the patient better. Like, are we the right people to be able to manage this patient? Or do we need the specialist orthodontist? Do we need the ENT specialist? Do we need the lactation consultant? Do we need the osteopaths, and so on, right? And most of the time, patients need to actually realize that, we cannot work alone, So like me as a myofunctional dentist, I cannot work alone, because as a dentist, we are limited to be able to work around the mouth, the face, the head, and the neck kind of thing. But, when it's the posture and the cranial system, the nervous system, we do need to help of the body workers. When it's the airway, we do need to help of the ENTs. So I would like parents to really realize that if you would like your child to be able to, assess and manage holistically, you cannot just see one functional practitioner. Basically, you need to see,
Yeah.
most likely need to see 2, 3, or even 4 sometimes. Yeah.
And I think it needs someone like you to be the architect of who they see and when, because I think what you said is a valid point, but sometimes it's a bit overpowering for parents.
Yeah.
Yeah. Now I'm going to summarize, Donny, what I think we've covered in this podcast, and I know this is going to be popular with parents. And first of all, congratulations on the book. And
Thank you.
I know in the child health space, it was #1 bestseller on its release. So let's hope it stays at the top of the chart. But I'd like
Thank
to
you.
say that Behind the Smile, written by Dr. Donny, kind of invites parents. It's written for parents, to look deeper. Behind the symptoms that get brushed aside, and some of those symptoms we've already discussed in this a podcast. I think this is a very compassionate book because it really follows the story of Ethan, and it really, I think, reveals the overlooked connections between a child's oral health, oral development, their airway health, and their overall well-being. And it seems to be, even at dental school, Donny, you made this point in the book that you had to go to the endodontic department if you had a person who had a root canal. You had to go to the prosthodontic department. But really, it's the same person. It's the same mouth. It's the same overall well-being. So I think what you've done in this book is really link that oral development, that airway health, and that overall well-being tremendously. I mean, I love the story of Ethan. I'd love to meet him and his family one day, because I think, both have contributed to the book. And you guiding them has given just the most spectacular end result for that family. So to summarize, for parents, if you've ever felt dismissed, frustrated, or desperate for answers, I think this book is going to offer you clarity, hope, and a new way forward. And it's going to help your child grow and thrive as nature intended. So, Donny, thanks so much for your time. I know we've gone a little bit over.
Thank you.
But congratulations once again. Thanks for all you do. And once again, I'm always going to try and say, Donny, can you please come to Sydney? We need you in Sydney. We need a Donny and Co. in Sydney. Yeah.
Thank you very
Donny,
much, Derek. Thank you for having me. And just for the listeners out there, the book is available on Amazon.com and Amazon.com.au. So you can get them, and I'll be actually launching it in Malaysia in February, and also taking it to the IOM conference in September next year, October next year as well, in Hawaii. So so it's good if if more and more parents out there can read about this, about Ethan's journey, and then see whether it resonates with their own journey.